Good day and very welcome again to the assessment of the fetal status using the cardiotachograph. I'm Anna Nolte and you have progressed to lesson 6 already. We're going to do complicated CTGs. In part 1 we're going to talk about the abnormalities of the baseline or the basal rate and abnormalities of the baseline variability. And in part 2 we will talk about all the abnormalities, decelerations, little bit accelerations, which is not an abnormality, and then we'll also talk about the contractions and the abnormalities regarding the contractions. I hope you still enjoy your course, and I hope that you still gather some new knowledge. Okay, now when we talk about the abnormalities of the baseline, we talk actually about abnormalities of the heart rate. We've said that the definition of the baseline is the average heart rate between periodic changes over a 10-minute period. And the two major groups of abnormalities of the baseline is first tachycardia and bradycardia, and those are the two that we will basically discuss just now. Right, so the first abnormality of the baseline that we're going to discuss is bradycardia. As we've said, the definition of bradycardia is a baseline heart rate of below 100 beats per minute lasting for more than 10 minutes. And we will categorize a mild bradycardia as a heartbeat or a fetal heart rate of 100 to 110 beats per minute. And we have said that it's very normal for a post-gestational fetus between 41 and 42 weeks of gestation to have a heart rate of 110 beats per minute. But what is important when we have a heart rate of 100 to 110 beats per minute is what the variability is. If there's a good variability, then there's no cause for alarm and we are happy. But the moment that there's a loss of that, we have a bradycardia together with a loss of variability, we are worried because that might be a sign of fetal compromise. And then very, very, very important that we have said several times now on these slides is how important it is to determine the maternal heart rate, and specifically so when we have bradycardia, because we have said that it's very often that the maternal heart rate is faster during labor because of anxiety and stress, but also for some other abnormal reasons, like for example antepartum hemorrhage. And it's then quite normal for the maternal heart rate to be in the area of 110 beats per minute, which we also see is now the fetal heart rate when there's bradycardia. And that makes it so easy to confuse, and I will show you an example of that later on. So we have to record the maternal heart rate with a CTG on the graph, and if that's not possible, we have to do it manually and write it then on the graph. Then causes of bradycardia is many. Fetal hypoxia is a very common one. And then fetal congenital heart block, some congenital abnormalities of the fetal heart. Maternal hypotension might be one of them. And specifically here, an example is when the mother is lying on her back and all the big fetus is pressing on the vena cava inferior and the aorta, and the circulation, the blood return to the maternal heart is much less, and eventually to the fetoplacental area, and that causes hypoxia and bradycardia. Also uterine rupture, and specifically where there's a previous scar, and we get a little bit of the scar is starting to rupture. We might also get fetal bradycardia. Placenta abruption is another example. Cord prolapse, we might also get decelerations, but also eventually bradycardia. Or a rapid descent of the fetal heart might sometimes cause a bradycardia. Here's an example of bradycardia. Here you can see the fetal heart is around there's 60 beats per minute, 70, 80, 90 beats per minute. So this average fetal heart rate here is about 80 beats per minute. In this case, we do see that there's still good variability, and that there's even some little bit of accelerations there. Bradycardia is always one of the characteristics of a CTG that one has to really carefully examine, and when we come to the different guidelines, we will also see that a bradycardia is usually, we classify it as being abnormal. Now, we have talked several times about the importance of monitoring the maternal pulse, and I have told you how easy it is to confuse the maternal pulse with the fetal bradycardia, and the example here in front of you, you can see it very clearly. You can see here on the graph that the maternal pulse is 100 beats per minute, and there's 120 beats per minute. So it looks as if this heart rate that we see here in front of us is 110 beats per minute. There's even a little bit of variability present, and there's even a small deceleration present. And when a cesarean section has been done on this mother, the baby was born macerated. So it's very clear that it was the maternal pulse that have been monitored here. And that is just, again, a big warning to not confuse the maternal pulse with the fetal pulse. Then our second kind of or type of abnormal baseline fetal heart is tachycardia. That is where the fetal heart rate is greater than 160 beats per minute for longer than 10 minutes. And here are all the causes of fetal tachycardia. Fetal hypoxia is one of the main. Remember when we did in lesson 4 the physiological changes, that eventually after persistent hypoxia, the fetal adrenal glands are being stimulated, and that eventually cause tachycardia. So here is tachycardia, there's obviously one of the main reasons or the main effects of fetal hypoxia. Another big possible reason for fetal tachycardia is maternal pyrexia, and that's also one of the first things that one can go and look for if you find fetal tachycardia, is to go and look at what the maternal temperature is, because we often get that. And together with the maternal pyrexia is chorioamnionitis, which will obviously also to a certain extent cause maternal pyrexia. Then the administration of some medications, except, for example, parasympathetic blockers, for example, atropine, can also cause tachycardia, and then also some of the drugs that we use for tocolysis can also cause fetal tachycardia. Drug addition in the mother, if depending on which drug she is being addicted to, some of the drugs do cause maternal tachycardia and then also fetal tachycardia. Maternal hypothyroidism might be a reason. Moderate constriction of the cord might sometimes cause fetal tachycardia, and then we have said that sometimes epidural analgesia cause a temporary maternal pyrexia, and that causes the fetal tachycardia. Now, some very important aspects of tachycardia is it's not always associated with hypoxia, like we've said so many times before, if there's good accelerations and good variability. Good variability, like we have said, that the good variability is usually a good sign of that there's enough oxygen going to the sympathetic and the parasympathetic system. So when we have tachycardia and there's good accelerations and good variability, we have to assess it very carefully, and we have to monitor it very carefully, but it might be a normal CTG. And then it's also, like we've said on the previous slide, very important to check the maternal history for possible causes. For example, maternal hyperexia, medications that the mother is on, etc. It's important the moment that we get recurrent decelerations as well as a loss of accelerations and decreased variability. So the moment that we have tachycardia together with another abnormality, like for example decelerations, and a decreased variability, we usually have a problem and also need to assess the condition much more carefully. A rising baseline, even within normal parameters. So say, for example, the normal baseline of the fetal heart was in the area of 130 beats per minute. And then gradually, next time you measure it, it becomes 140, and next time 150, and next time 160, is a sign of adrenal stimulation. It's a sign of, like we've said, persistent hypoxia, which cause the adrenal gland to be stimulated, which cause the secretion of catecholamines, etc. So that is very, very important. Here's a typical example of fetal tachycardia. In this case, the fetal heart rate is about 200 beats per minute. There's initially not a fairly good variability, and then eventually the variability becomes less and less, and yes, almost no variability, this last part of the CTG. So one needs to definitely carry on with the monitoring of this fetal heart to see what's going on with the variability, whether it's decreased or not. Then when we look at the abnormalities of variability, there are basically three classes of, or three groups of abnormalities of variability, namely decreased variability, increased variability, and sinusoidal patterns. Our first abnormality of variability is decreased or reduced baseline variability. We've said that normal variability is between 5 and 25 beats per minute. So a reduced or a decreased variability will be then a variability of less than 5 beats per minute for 50 minutes. Now, we remember the reason why we use this 50 minutes is because of the possibility of the sleep cycle. And we come to here, we've said that one of the possible causes for a decreased variability might be a sleep cycle, where the fetus is asleep, and we've said that there's very little interaction between the parasympathetic and the sympathetic nervous system during the sleep cycle. And these cycles usually last about 20 to 30 minutes. But what we need to remember is that during these sleep cycles, the variability is seldomly less than 5 beats per minute. It's decreased, but we seldomly see just one straight line, as in many cases of hypoxia. Most of the analgesics and sedation cause a decrease in variability, baseline variability. If you, for example, give a mother pethidine during labor, it's very highly likely that you will find decreased variability of the fetal heart after that. Or if the mother is on some other sedation also, when any sedation or analgesics that suppress the nervous system of the mother will also suppress the nervous system of the fetus, and with decreased variability. Now, in the absence of any of these fetal sleep cycles or analgesics or medication that cause the decreased variability, it's highly likely that this variability or lack of variability has been caused by hypoxia. And then obviously not enough oxygen supplied to the central nervous system, and specifically the sympathetic and the parasympathetic nervous system. And it decreased both of their activities, so it decreased the increase as well as the decrease of the fetal heart, this fluctuation in the fetal heart, and therefore a reduced variability. Now, in the case of a persistent reduce, and remember we've said that usually in the sleep cycle it's initially reduced and then it stops. If it's persistently reduced, or if there's no variability, the one single most important factor is fetal compromise, a lack of oxygen to the central nervous system. And then also the fetal, if together with this lack of variability, if there are decelerations or a bradycardia as well, it is there's a very high risk of acidemia and immediate death and asphyxia, and probably brain damage as well. Here you have an example of tachycardia. If you look at this graph, you can see here's 150, 160, 170, and 180 beats per minute. So we have a fetal heart rate here of just below 180 beats per minute. And you can also see that there's very little variability present as well. Now, our second abnormality regarding variability is increased variability. We've said normal variability is between 5 and 25 beats per minute, so increased variability will be above 25 beats per minute, and we call that a saltatory pattern, and that's what you typically can see here. There's a lot of variation here, and if this lasts for more than 30 minutes, it might also be associated with rapidly evolving hypoxia. The third abnormality of the baseline variability is the sinusoidal pattern. It appears as a regular oscillation on the baseline. It looks like this typical pattern that we always drew when we were children, and I will show you an example of it just now. And possible causes of that is fetal anemia. For example, in the case of a RH incompatibility where the fetal blood's been hemolyzed by the antibodies already, and we get a fetal anemia. In the case of the serious maternal anemia, and that often might placenta abruptio might be one of the reasons for that, or where there's some or other reason for a fetal maternal hemorrhage between the placenta and the mother and the fetus, if I can call it like that. And the last possible cause for the sinusoidal pattern is an acute intrapartum asphyxia. Now, we get a true sinusoidal pattern and we get a false sinusoidal pattern. Now, a true sinusoidal pattern lasts usually for longer than 10 minutes, and it has an amplitude of 5 to 15 beats per minute, rarely greater. So it varies basically between 5 and 15 beats. And it's a frequency of 2 to 5 of these oscillating cycles per minute. And it has a fixed flat beat to beat short-term variability, which I will also show to you now. And this oscillation of this sinusoidal waveform just happens above and below the baseline. So you just see it going up and down, above and below the baseline all the time. And there's no areas of normal fetal heart rate variability in between as well. Here you can see an example of a true sinusoidal pattern. You can see here this typical sinus wave, and it basically, here you can see 120 beats per minute, 130, 40, 50 beats per minute. So you can see this fetal heart rate has this wavy pattern here between 140 and 150 beats per minute all the time, and it goes on and it lasts. In this case, this is 10 minutes, another 10 minutes, it's 20 minutes, and this is almost going on to 30 minutes, and this is a typical true sinusoidal pattern. Here you can see a false sinusoidal pattern, and the typical difference between a false sinusoidal pattern and a true sinusoidal pattern is what you can see here. Here you see this wavy part of the sinusoidal pattern, and then it just goes over into a normal pattern where there's normal variability and normal accelerations, etc. So this, as I've said, a typical false sinusoidal pattern. And that brings us to the end of lesson 6, part 1. where we've done all the abnormalities of the baseline and the baseline variability. And then I'll see you in lesson 6 part 2, where we'll do all the abnormalities of the decelerations and the contractions.